What do nurses do commonly in the ICU or in a critical care unit? They do charting, they do assessments, they do vital signs, IOs, care plans, verbal orders, data retrieval. All this is part of their work, and this data has to be recorded by the nurses. Now, when that is done using IT, this study showed very sick and they need constant attention. And the other glaring fact, 75% of the data elements on paper forms are duplicates. So, since there is no other way to do it, they have to do it this way, copying the same numbers again and again and leading to errors and time wastage. A snapshot of some of the EHR benefits. There is increased billing capture, decreased billing errors, radiology savings, lab savings. I'd like to point your attention to the adverse event prevention and the drug savings. Put together, it's coming to about 47%, 44%. So, huge savings across the board. Some of the key benefits: delivering better, safer, quality care, secondary use of this data, business intelligence is possible for management and for clinicians who are interested in research and they want to publish these papers. You can optimize the hospital resource utilization using your IT services. Repetitive, laborious work is automated, resulting in reduced errors. Clinical decision support can be provided to clinicians at the point of prescribing. It reduces medical errors using CPOE, and e-prescribing along with MAR, which is what we call as the closed loop medication. So what we aim for is every player in healthcare having right information at the right time and data driving efficient, high quality, evidence-based healthcare. I'll talk a little bit about the India healthcare landscape. So we all know this, but I'm just summarizing it. We have the government and the private as two big players. The government predominantly concentrates on preventive medicine, and they have something like 23,000 primary health centers across the country. These PHCs provide curative, preventive and family welfare services, and a PHC on average covers 100,000 population. Now PHCs report into community health centers. There are government medical colleges, government hospitals, and the National Rural Health Mission, which comes under the Ministry of Health, is spending a lot of money to upgrade services which are being delivered through these primary health centers. Private, as we know, provides predominantly curative medicine. We have something like 8,000 hospitals, mostly in the cities. Several hospitals are either JCI, ISO, NABH accredited or in the process of getting their accreditation. So, a little bit difference between the private sector and the government sector, the way they look at healthcare IT. In the private sector, they look at it to reduce the medical errors and optimize resources, whereas on the government side, they need data integrity, because that data is what is used to calculate the amount of funding which goes to for preventive medicine. Some of the emerging initiatives in India, some of us may be aware of these initiatives. Central government run Rashtriya Swasthya Bima Yojana. It's a healthcare insurance policy for below poverty line people, and these people pay 30 rupees to get a card, which makes them eligible for 30,000 rupees worth of treatment. And this is actually empowering patients, because then the patient can choose to go and spend that money where he wants to. And there is biometric authentication on the card, so that these cards are not misutilized, and the recipient is the only one who can use that card. I'll talk a little bit more about it, is the Indian Health Information Network development. A lot of effort going into it as we speak. UID, led by Nandan Nilekani, another big project done by the central government. So each of us in India will have a unique identification number, which gives us the potential to use that as a UHID, unique health identification number too. And IT again playing a major role in modernizing healthcare in both private and government. As we speak, Andhra, Hyderabad has been a leader in some of these initiatives which we talk about. Arogya Shri, about which tomorrow there will be a lot of talk, started in Andhra in 2007, and within 3 years, what we are seeing is from 163 diseases, they are now covering almost 1,000 procedures. So they have launched Aarogyasri 2. They are covering more diseases and they are taking care to more people, and they are targeting about 70 million population. The success of Aarogyasri in Andhra Pradesh has been utilized in Tamil Nadu. A similar scheme has been launched there, and these are all for below poverty line segment as of now. So the amounts vary, the eligibility varies, but the basic principle is the same. The government, from just spending money on government hospitals, is now giving it to the patients in a way that they could actually have the choice in their hands, and they get to spend the money where they want to. HMRI is Health Management Research Institute, again based out of Hyderabad, and these people are creating the world's largest integrated digital health network. They provide a mobile PHC and they deliver healthcare at home, and they reduce the cost of access to healthcare services for people. The morning we heard one of the doctors was a cardiac surgeon who said that just to do a medical test, the patient has to travel all the way from his village to the city. Now HMRI is bridging that gap. They are providing access to regular preventive health checks, health education, a lot of care. It's very interesting the way they pitch it. They say, why should the patient come to the PHC? Can't the PHC go to the patient? You know, brilliant concept. And HMRI, we'll hear more about them. Their CEO is here. It's a wonderful initiative which they are doing here. iHind came out of the National Knowledge Commission recommendations led by Mr. Sam Pitroda. It's the NKC itself was under the Prime Minister. The iHind plan was tabled in Parliament in October 2008. These are the three components of iHind. You have the India Health Portal, you have a Health Information Network, and you have a National Emergency Medical Services. The unique thing about this project is it is done completely by volunteers, and 80 plus volunteers are collaborating across 4 countries. It was done over 6 weeks, and a presentation was done to Ghulam Nabi Azad and Dinesh Trivedi on 16th of April, and they have asked us to do a pilot in one of the districts in Rajasthan. So in September they would be doing a national level conference and request the state governments, because health is a state subject in India, to take ownership of iHind and take it forward. Now what is iHind? iHind is a health information network. I'm talking only about the health information network part, in a hub and spoke model. So we look at India as 626 districts. Take one district, plan for that is district in a hub and spoke model, and connect all these spokes to the hub. And the target is to be financially self-sustaining in about 5 years. A graphical representation of iHind. It includes everything, but to start with, we are starting with the public health institutions and public health data, which is owned by the government. Over a period of time, radiology, the clinics, pharmacy, labs, district hospitals, medical education institutions, all of them will be feeding data into this into the hub. And the secondary uses of this data is what is shown on the other side. Data reuse, and the government will actually set up a National Health Information Authority who will oversee how this data gets used. Some of the standards, we heard Professor Ananta Padmanabhan say in the morning that in Hong Kong they are following standards and they are able to do a lot of connectivity. So standards are key, and without standards, we very soon end up in a situation where on the same desk you have 3 systems into which you have to log in, get little bits and pieces of information. So the team is aware of this, and these are the standards to begin with. Vocabulary standards, ICD-10 from WHO, SNOMED CT, content exchange standards, DICOM for images, HL7, CDA, transport standards as in SOAP XML, and of course privacy and security standards. And this is a start list. As the pilots evolve and progress, more and more standards would get added to this. The Health Information Authority would be the custodian for the data will be formed